Good morning. This is Dr. Patwardhan from Sanchit Institute in India, talking to you about capital realignment of high-grade slips using an anterior approach and osteotomy. I and my co-authors have nothing to disclose. Unstable high-grade slips, the optimal treatment should be technically simple through a familiar approach, should minimize complications like AVN and chondrolysis, and should minimize residual deformity causing impingement. This is a single surgeon study, a retrospective study of 24 patients between 13 years to 17 years, done between 2013 to 2017 with a 3-year follow-up. My method, which is available at the POSNA Academy as a video abstract, is through an anterior Smith-Peterson approach. We reach the capsule and do a capsulotomy, which decompresses the hematoma. And then with a base anterior, apex posterior short of the flap, we resect 6 to 8 mm bone, and the neck is then gently reduced onto the head lying posteriorly in flexion internal rotation, and with extension comes anteriorly. Then we stabilize the head with 7 mm cannulated cancellous screws and check the blood flow to the head with small drill holes. We evaluated our outcomes with clinical hip range of motion and on X-ray with Southwick angle and the lateral alpha angle, and looked at complications. Our results were encouraging, and we could correct the Southwick angle and the lateral alpha angle to a great extent, and we had very good range of motion in most of our cases. Our operative time was about 40 minutes with a blood loss of less than 50 cc. 3 of our cases had avascular necrosis, and there were no implant-related complications. This is an example of a high-grade slip which has been treated with the technique as mentioned with a good outcome. And this is an example of a case through the same method with an AVN, but we do not know whether the posterior flap was intact or torn prior to surgery. If you look at the literature, safe surgical dislocation has become a popular approach to head realignment. But it's a difficult surgery with a higher learning curve and more time for surgery with more blood loss, and complications of implant failure have been noted. And did it really bring down AVN rates? Literature reports them between 15 to 40% with an average of 23% AVN even with an SSD approach. Our series compares favorably with AVN rates of Schlongo, Parsh, and Chen. Our anterior approach was inspired from Professor Parsh's work, who did an anterior open reduction and gentle reduction for slips which were unstable with a minimal AVN rate of 5%. There is a French paper with the similar concept which has been published, which puts the AVN rate at about 13.3% through an anterior approach. So we want to conclude that this is a familiar anterior approach which most surgeons know. We get very good deformity correction. The AVN rates are comparable. There's no implant-related complication, and you have much lesser operative time and blood loss. It's a small series with a short follow-up, and more study needs to be done. Thank you very much.